Our next speaker is online, so I will look to colleagues to set her up. But Yoon from the World Health Organization has been doing a lot of thinking about how modelling can be used to inform policy, particularly in the vaccine space. But this is obviously relevant for lots of areas, and I think the thinking that they've been doing will be really useful for us to think about today. So I'll hand over to you. Can you hear us okay?
Yes, very well. Thanks, Theodora. Hello, everyone. My name is Soyun Sim from WHO Department of Immunization and Vaccine and Biological, and I'm currently a technical officer as part of the Value of Vaccine Economics and Modeling team. I'm very pleased to be here today and share our experience from WHO perspective and potentially the complement this the routine immunization perspective to the talk around the preventing the future pandemics. So let me just take a moment to share my screen. Do you see well from your side?
Yeah, thank you.
Yeah, thank you. So let me start with the Immunization Agenda 2030. So let me give you a context of where this talk is coming from, and then I would like to also share our ongoing initiative on developing a WHO guidance to help translate vaccine impact modeling to informed decisions. So first, to start with, the Immunization Agenda 2030 was co-created at the end of last decade with the all immunization partners to set the strategic direction for immunization and for the decade 2021 to 2030 for this shared vision on the right. So a world where everyone, everywhere, at every age fully benefits from vaccines for good health and well-being. So there are 3 impact goals and 7 strategic priority areas and 4 principles on the left that have informed the strategic direction and priorities for the partners. And these are well aligned with the Sustainable Development Goal 3 Global Action Plan and WHO's own global program of work. So for WHO IBD, Immunization Department, our mission is firmly grounded in this IA 2030 to advance the impact of vaccines, immunizations worldwide through global leadership, generation and dissemination of research, evidence-based policies and guidance, and provision of technical assistance, which is closely coordinated across 3 levels, from HQ in Geneva, where I'm sitting, to the regional offices and country offices. And as part of this department, our team, Value of Vaccine teams, its main mandate is to provide member states, global policymakers, funding entities, and R&D community with normative guidance on robust modeling approaches and the economic method, priority setting, eventually through the IVRA committee, which I'll explain in a bit, to assess the full, inform the assessment and communication of the full value of vaccine across the vaccine life cycle. So focus of the talk today will be on IVRAG and modeling, but I'll also touch upon a relevance of this guidance to other work streams at the end of this presentation. So modeling has played an important role for IA 2030 because it helped to set the targets and monitor the progress for the agenda. So it provides modeling estimates for impact goal indicator 1.1, which is a number of the future death averted globally from vaccination delivered during the decade. So we have published scientific analyses using the analytical framework. Is a mix of estimates coming from the Vaccine Impact Modeling Consortium, dynamic transmission models, and the static model that we developed for 4 other pathogens, complemented by the statistical framework to extrapolate the estimates to the locations where there are no modeling estimates. And then based on the aspirational coverage scenario we envisioned for 2030, we also estimated the resource needs to achieve this coverage targets. And these were used to set targets, which is 50 million lives saved by 2030, and also most used heavily for the advocacy during the beginning of the decade. And we also support with the monitoring and evaluation efforts. By using the same model, we annually track progress against the targets that we set in 2021. And more recently, this year marks 50th anniversary of expanded program on immunization, which was launched at the World Health Assembly in 1974. So building on the analytical framework we initially developed for I-2030, we estimated the impact in the past 50 years. In short, it is 154 million deaths averted due to immunization efforts in the past 50 years, and out of which the 40% of the reduction in infant mortality is attributed to the vaccination. So this was used during the World Immunization Week to launch this humanly possible campaign, and also highlighted again during the World Health Assembly. So this was predominantly more advocacy-oriented efforts. So today, today's talk, I'd like to focus more on how the vaccine impact modeling has been used for decision-making. And let me first start with this figure synthesizing the relationship between different levels of decision-making at global, regional, and country level. The first is the Strategic Advisory Group of Experts on Immunization. We call it SAGE, and you may be familiar with the entity because of vaccine position papers and the roadmap for prioritization for COVID-19 vaccines, as well as some product-specific recommendation came out from this advisory group. Which provide the policy recommendations as well as overseeing the development and the progress of the I-2030 strategy. And we have a similar structure at the regional level. Each WHO regional office hosts the regional technical advisory group on immunization to inform the regional level strategies. And at the national level, finally, we have national immunization technical advisory groups who make a recommendation for any vaccine introduction or other relevant policy decisions. And also, as you see in this orange mark, highlighting the decision-making points. It informed national level immunization strategy to help with the programmatic priorities, budget setting, to aid national authorities to make decisions on this matter. So going back to the SAGE, they meet twice a year, the evidence twice a year, and then composed of the 20 members. And I have to actually highlight again, all three levels, the major principle is the evidence-based decision-making in public health that synthesizes utilizing the best scientific evidence available, as well as other factors such as context, equity, feasibility, affordability, and sustainability. So to describe how the SAGE review this different type of evidence ranging from the trial and observational data, programmatic evaluation, economic evaluation to the impact modeling, and any other qualitative evidence that the SAGE considers relevant. So they use the GRADE method, the grading of the recommendation, assessment, development, and evaluation to assess the certainty and quality of the evidence. And at the end of the day, this really, all the evidence review is summarized into evidence recommendation tables, which serve as a basis for the SAGE recommendations and balancing the benefits and harms of the intervention, but also the implementation concerns as well as future research priority. So for the modeling, as I mentioned before, it is used as a very critical part of the evidence review by SAGE. However, there is no broadly agreed upon the quality assessment criteria. So assure this, the SAGE relies on the WHO's Immunization and Vaccine-Related Implementation Research Advisory Committee. It's a long, acronym is, we call it IVRAC, which is one of the three major also advisory group as part of our department. Along with SAGE and Product Development Advisory Group. But this specific committee provided independent reviews and appraisal of the quality of the modeling method and evidence. So, however, global level, it has been very routine in using the modeling evidence with the support from the IRAC, but the use at the country level has been very limited for routine decisions, not just because of the modeling capacity of in generation of the modeled evidence, but also the decision makers' capacity to interpret, translate, and apply modeling evidence. Due consideration is also to be made because modeling is just one aspect of the broader type of the evidence that decision makers consider. So good news, after COVID-19 pandemic really gave preeminence to modeling and then supported government with their planning and decisions. But also there's a lot of reflections that followed the pandemic about the use of modeling. So 2 years ago, I was sitting in the audience of this modeling to support resilience for pandemics organized by the Newton Gateway to Mathematics. And then all these reflections and initiatives started by the low and middle income country decision makers, funders, highlight the importance of increasing the capacity and then strengthening the capacity development, not just for the modelers, but also the decision makers. And then, as you may know, this Lancet Commission is currently working on providing recommendations for strengthening the use of the epidemiological modeling of emerging and pandemic infectious disease. So we are also collaborating with the Commission to find the synergy between the two efforts, and also we can complement from our own routine immunization perspective to this initiative. And then I'll move on to our current ongoing effort. So it's not just the modeling field, but also the COVID-19 modeling triggered the IRAC's response to, and then the need to expand their mandate more to the country level. So the working group, we call it IRAC subgroup, was established in March 2023 to facilitate the effective translation of modeling to inform decisions. And our target audience includes the NITEC and RITEC members and immunization technical working group members and any technical partners who are supporting decision-making. We started with the more comprehensive needs assessment qualitative study to understand the needs of the end users for immunization decision makers. And based on this study really has informed the content and format of the guidance. It's currently being developed, and we hope to deliver it by early 2025. And then IRAC full committee also review the content and provide appraisal. And then based on the finding of the study, we hope to continue with the training and ongoing support through existing mechanism. Here's a quick overview of who has been supported this initiative. So the work is led by the IRAC chair, Professor Shital Silal, and then from WHO Secretariat with the 5 members who are coming from different disciplines. And the modeling draft writing itself is led by the 2, the Uchrada Panyum, Dr. Panyum, and then Dr. Jackie Oliwa from Thailand and Kenya. And then we also the support from the University of Sydney on the qualitative study, and a close collaboration with the regional office so that this guidance can be eventually useful across all regions. And let me jump on to share more about the findings that we received from the qualitative study. So qualitative study itself is really based on the behavior model. This is a COMBI model system, behavior system that shows these 3 elements that influence the behavior, which in turn influence again these 3 components. So based on this model, the decision maker can understand modeling and the motivation. They are motivated to and want to use the modeling, and they have the opportunity to have the resources, time, models, and professional norms and support to use the modeling. So we really benefited from the social and behavioral science expertise from the University of Sydney SABI team, who conducted this needs assessment with the three objectives. First, identify how modeling is currently used by immunization decision maker and the needs and challenges and the type of guidance they think will be most useful for themselves. So here, matrix sample shows, so we ended up interviewing 15 interviewers across 6 WHO regions and different income groups. And you see here are different decision categories to capture different type of decision made in the immunization field. So first, about results about how they're currently used modeling. So first, let me just share some of the highlights from the study. So all understood modeling be a way to look for and quantify the health outcomes, but there is a discrepancy between the ones with less experience with modeling and then the ones with more experience with modelings. So as a word, I understand perfectly, but as a process, I'm a little confused, which is a statement by the EPI manager from a middle-income country. So they have much less confidence and the passive consumers and only a limited or no exposure to the modeling work or ongoing international efforts around this. Interview with the more experienced they tend to use the modeling firsthand, and also they use it in their advisory capacity. And all who have used modeling this so to plan ahead, also with the economic considerations in mind. Another statement highlights the need for increased understanding of how modeling could be actually used in their day-to-day task and how in the immunization their function. The second set of the result shows the barriers to using modeling. The first, knowing what it is and what it can do. And second, seeing its relevance to context. So from time to time, this NITAG member said that they thought that the thing was missing was the data formula, and they didn't give us a clear source of information, and it really made them wonder whether it is applicable to the situation or not. So this shows that these first 2 points that I mentioned. And also the time constraints and trust in modeling and modelers are the significant barriers. They're only given 20 minutes to understand the complex model. And then at the end of the day, it's just not about this level of the trust in the modeling as a discipline, but also the level of the trust in who is delivering the model. The modelers themselves is a really important factor for them to motivate them to use it for decision making. And in addition, another concrete barriers regarding the conducting, assessing, and communicating models, as well as lack of existing data, capacity, and resources. Finally, for us, it is also to understand what type of guidance would be most helpful for this decision makers. So here, one of the NITAG chair mentioned that it should be very smart and not difficult to use, and considering the limitation of the time and then bandwidth of their colleagues. So the document to be presented in a user-friendly manner, allowing for easy interpretation, even by those who don't have much extensive experience. Also, they prefer interactive conversation or electronic training course. We may need an interactive conversation to exchange ideas and discuss with the one who may have more experience than us, which would be very helpful. Mentioned by the NITAG member that ongoing interactive training and community practice will be proved useful. And there's a mention of the relationship brokering to address the trust issues, and the guidance eventually also needs to cater to the different levels of literacy. So we are currently disseminating the results for very different platforms involving immunization decision makers, and also this is to be submitted for peer review. Right now, we're developing a guidance document based on the findings from these assessment. And then just to give you a snapshot of what's going to be included in the guidance, we really focus on the decision maker's perspective on why should I use this guidance and what does the modeling process look like, and when and how should I be involved, and the result when I look at the result, what should I look out for when interpreting the results, and the knowledge translation aspect too. How could I implement modeled evidence to inform decisions? And finally, this is the ways of working. How can I work together effectively with modelers? So this is currently being developed, and we really look forward to finishing this work by 2025, and also having the opportunity to share with the platform like this workshop. And just to conclude my presentation, going back to the work stream that our team is involved in. So we believe that this could not only just for the modeling, but also find synergy with the other area. For example, WHO already has a guide, WHO guide for standardization for economic evaluation of immunization program, which really focus on the model-based economic evaluations. And we also have a capacity decision tool, which is currently being deployed at the country level to help countries with prioritization or portfolio optimization related decisions. Finally, there's a full value vaccine assessment, of which the modeling is a critical part to demonstrate the disease burden as well as the vaccine impact. So we hope that it's not just for the modeling per se, but in all the other areas, this guidance will support decision makers to effectively use and translate the existing evidence for their decisions. Yes, I'll stop here, and thank you very much for listening, and thank you for organizers for providing me with this opportunity to share our work. Thanks.
Thank you very much. Thank you very much, Yoon, for that sort of global perspective. Really interesting insights, particularly from that survey. And I'm glad to say that Pan, the lead modeler, is here on the programme, so lead modelling writer. So we can also catch up with her later on today. So we have 10 minutes for discussion, or 7 minutes by the counter. So does anybody have any questions first for Yoon? No? Okay. Or for Stephen, if you don't mind, Stephen, taking a couple of questions from Stephen's talk. Okay, I'll start with Yoon. So was there anything surprising in that survey to you? I mean, I think these are comments that we often hear, and we haven't really found a way to overcome them. Was there anything particularly surprising for you?
I'm also aware of lots of other qualitative studies that is currently taking place. So at the end of the day, when we developed this guidance, we also took into consideration all the findings from those interviews with the decision makers. Not particularly surprising itself, but I think one of the resonating theme that we keep seeing is this the trust issue, and then how this not just at the modeling itself, but also at the interpersonal level with the modeling groups is an important vector. So I believe in the pandemic prepared setting, I think there's a lots of also active discussion around what the structures and then what the structures and the mechanism that this knowledge translation should look like. So this is something that we need to consideration. And also this is where modeling community could greatly benefit from the social and behavioral science expertise.
Thank you very much. Pan, I have now spotted you in the room. What did you find most interesting about being part of this process with WHO?
What I found as a surprise is much more difficult to write a guideline than I expected. But I guess I'm not a very technical person, and so I mean it's quite appropriate to think like putting myself into someone's situation where all you need to know is can I really use that model in a very limited time to make a decision. So I think we just have to do a useful guideline in terms of putting ourselves into that situation. So it's been a great experience for me to do this.
Thank you, Pan. Any other questions in the room or on the Zoom as well? Oh, John, please go ahead.
Yeah, I actually spent 7 years on Iverac and its pre-runner Quiver it was called before. My experience with it, it's a valuable committee, but I don't know whether it has enough teeth really to really make a difference. What I found was that quite often the work that was coming was not of the greatest quality. It perhaps didn't really, hadn't been really fitted to data very well, and made the best use of data. And often it had been done quite quickly. The work had been commissioned a few months earlier or something like that, and I found it a bit frustrating that we kept getting this, and it was quite difficult. When there's a committee and it's quite small, and not all of the people on the committee are kind of modelers, so it was quite it's quite difficult sometimes to say no. That really this piece of work might not necessarily advance things. So not knowing this might be better. Go out. And what I found was, because it has really very little money or resources, often the answer is go and collect the data. When you really don't have it, just modelling over, just making broad assumptions and hoping, I don't think is the right approach. I think the answer there, when you really don't have the information, is to go and design a study and collect the information. That's what we should be doing. And I found, I don't know about your reflections, but I found that we should be doing more of that, particularly at WHO level, and particularly with that committee.
Thank you, Yoon. I don't know if you could hear that, but would you like to respond to John's comment?
Yeah, sorry if I didn't fully capture, but to answer your question. So thank you, first of all, for sharing your thoughts as coming from a formal IBRAG member, and we really appreciate all the contribution made by the IBRAG member. So given so first to answer to address this point about the limited number of the modelers as part of the committee members. So actually, that is intended by design to draw not just the modelers or economists, the more quantitative methods expertise, but IBRAG over time has increased its membership profile to include more rich background coming from the programmatic side or implementation research experts to be able to more provide a comprehensive view. But to address this issue about more focused time needed for some of the appraisal, so now we are just like the SAGE, we have the working group set up, like subgroup set up, to really go in depth, delve into a specific disease area, especially for the SAGE policy recommendations, so that so each IBRAG member also can invite the external experts into this working group to have more people the oversee this appraisal process. And another, like, I think I really agree with you about the resource. We also face a bit of a resource constraint, so best work needs to be done given the limited resources, but also we heavily rely on this research network and academic institutions. So any recommendation and feedback that you have will really be helpful for future direction of the IBRAG and IBRAG subgroup. So we really welcome that, and then I hope this will create a positive feedback loop for the future work. And as I mentioned before, there's seem to be no broadly agreed upon the quality assessment and tool. So if you have any ideas, ongoing initiatives, so we'll be happy to also learn more about it and incorporate into our existing work streams. Thanks.
Thank you very much. So we've run into coffee, as the big sign is showing me. We do have a couple of questions online, one of which we'll store for the discussion later, and the other we'll pass on to Yoon and see if we can get a response to it. So thank you very much to those people online. There was one hand. Did you want to ask a quick one, Frank?
Quick question for Stephen.
Yeah, please.
So you mentioned that decisions are taken when they need to be. You'd mentioned that in the absence of knowing exactly what the challenge is, it's hard to design a survey beforehand, but perhaps you could do as much as you could to design a survey beforehand. So on that point, I just wanted to ask the extent to which over data, trying to establish a general purpose capacity to be able to absorb and collect and analyze data from the many sources of data the government has direct control over, and from the many sources of data which it doesn't. Whether whether you thought pretty hard about, say, how you build capacity to be able to react quickly when possibly unforeseen challenge arises.
Yeah, so there's within UKHSA, we're investing a lot in trying to streamline the way data flows within the agency because it's quite fragmented. So that will make it easier to use the different data that come into the agency during emergency, and part of that is providing an external data platform. So that's one kind of concrete step. And then there is more generally across government, there is a strong desire to create to join up valuable government data sets, and there's been talk of a government-wide kind of data library. I think that's motivated by the points that you've made. I guess the one caveat I would say is you have to be cautious joining data together for the sake of joining it together, because you'll never finish that job. But I think that there's kind of initiatives on that at 2 different levels.
Thank you very much. So it just remains for me to say thank you very much to both our speakers this morning, giving us plenty to chew on over coffee. And coffee is just outside the room here. And just a reminder that lunch will also be here for those of you who are expecting it possibly to be in another place. But once again, thank you very much to our speakers.